Hello there, my name is Ryan and I've created this video as a refresher for Ambulance Victoria, ALS and MICA paramedics in managing patients experiencing a seizure. So starting with what seizures are. Similar to what the slide shows, Tintinelli's emergency textbook states seizures are an episode of abnormal neurological function caused by inappropriate electrical discharge from neurons. What that means is that neurons are firing a large amount of action potentials. These electrical discharges can affect both hemispheres of the brain, being termed a generalized seizure, or specific areas of the brain, being a focal seizure. Today we will be focusing on generalized seizures. This excessive electrical discharge in generalized seizures can cause excessive muscular contraction or lack of, can cause sensory changes and sudden loss of consciousness. Important to note from the start is that seizures are a symptom. Similar to how chest pain is a symptom of a heart attack, seizures can be caused by many ailments, with some written on the screen and will be discussed a little bit later. Specifically, how seizures occur is due to an imbalance in the homeostasis of excitatory and inhibitory neurotransmitters, being either too much excitatory neurotransmitter glutamate or insufficient inhibitory neurotransmitter GABA, resulting in excessive neuronal action potentials. The reason why this video has been created is due to the serious nature of prolonged seizures. When there has been 5 continuous minutes of seizure activity or more than 1 seizure without returning to baseline GCS, the patient is then in status epilepticus. When a patient is in status epilepticus, it becomes harder to stop the seizure activity. As the cutout from Castle and Lajoie mentioned in their research, a seizure lasting longer than 5 minutes was unlikely to remit without medical intervention. A patient experiencing a prolonged seizure is at risk of short-term and long-term effects due to the seizure, and approximately 20% of status epilepticus cases result in patient mortality. Status epilepticus is a generalized seizure and a time-critical emergency that requires aggressive management. As we've already touched on, there are many different manifestations of a seizure, which makes the clinical features of an active seizure difficult to define. It is largely dependent on the type of seizure, and I'll do my best to touch on as many clinical features as possible. What is consistent among all generalized seizures is that they will all have a sudden loss of consciousness. The most common type of seizure is a generalized tonic-clonic seizure, which may have some or all of the features shown. The seizures have a tonic phase where all of the muscles contract, followed by a clonic phase, being regular synchronous muscular contractions, sometimes seen as arm and leg synchronous contraction and relaxation. An atonic seizure will have no muscle contractions, and patients will experience a sudden loss of consciousness and loss of muscle tone. Myoclonic seizures will have a similar appearance to a tonic-clonic seizure, but as the slide shows, clonic phase of the tonic-clonic seizure will have regular contractions every 1 to 2 seconds. Myoclonic seizures will have muscular contractions every 0.1 of a second. Absent seizures are difficult to diagnose. These seizures are typically self-limiting after very brief periods. How most people would have heard about these types of seizures would be daydreaming students. Paramedics are very unlikely to have to provide any interventions, however should be aware of these types of seizures and if recognized, pass on the information of suspected absent seizures. Arriving to a patient currently seizing will require a rapid assessment, however the priority should be management. Arriving to a still seizing patient will likely mean status epilepticus. A rapid head-to-toe assessment will need to be made to determine any life-threatening injuries, then managing the status epilepticus patient. Overwhelmingly, the physical examination will be conducted on the post-ictal patient. As written on the slide, the patient's consciousness will be impaired. They could be anywhere from alert to unconscious, but the post-ictal patient will have a GCS score lower than their baseline. The physical examination of a post-ictal patient will still require a head-to-toe assessment to determine any injuries that need management. We have touched on some of the clinical features of various generalized seizures, but what can we use to determine if a patient is genuinely post-ictal? An article written by Azar et al. In 2008 looked at post-ictal breathing and showed that significant difference in breathing patterns of patients post-seizure activity. It showed that deep inspiratory and expiratory breathing pattern in generalized tonic-clonic seizure compared to non-epileptic or psychogenic seizures, which showed rapid shallow breathing pattern. Another sign that some mica can utilize, and maybe ALS in the future, will be blood lactate levels. As the table on the screen shows, there is a significant rise of blood lactate in tonic-clonic seizure compared to syncope episodes. As we've mentioned earlier, seizures are a symptom, and if paramedics can determine the cause, they can begin managing the patient prior to hospital for better holistic care of the patient. The relative investigation would be the portion in determining the cause of the seizure. The list in the middle of the screen is something I put up earlier. The acronym vitamins is a list of common causes of seizures, which can all be seen within the more extensive list from Tintinelli's, with some of the common reasons being stroke, traumatic brain injury, hypoglycemia, hypoxia, and epilepsy. The AV guideline reminds paramedics of some of these causes and to treat if possible. What paramedics can do on scene is use information about the patient from others at scene to aid in diagnosing a seizure and determining the cause. For example, if paramedics are presented with a post-ictal patient and bystanders say the patient had a severe headache suddenly prior to seizure activity, that could lead paramedics to think stroke prior to seizure. Remember that generalized seizure will have a sudden loss of consciousness as compared to a syncope, which will likely have a lightheaded episode prior to loss of consciousness. If a patient is an epileptic, they may be able to recognize when they are about to have a seizure by experiencing an aura. An aura is a subjective warning sign to a patient about to experience a seizure. Patients may see things, hear things, smell things, or taste things as a prodrome to seizure activity and may mention it to paramedics or bystanders prior to seizure activity. Important to note as well is information about the patient's seizure. If a patient experiences seizures regularly, we need to know if something is different today to determine pre-hospital interventions required. For example, a patient in status epilepticus that has been provided benzodiazepines prior to paramedic arrival will affect subsequent interventions. Emergency clinicians need to know if a patient is likely to have more seizures, the types of seizures, the medications they're on, and recent changes to management. As I've mentioned a few times, paramedics are likely to arrive to a post-ictal patient. But if paramedics are with a patient when they first start seizing, the first 5 minutes should be focusing on fundamentals of care. That is, ensuring the patient is unable to hurt themselves from immediate dangers around them. For example, seizing on a stretcher could mean a fall from a height. Fundamentals also include the ABCs and preparing to administer medication. The cutout from Tintinelli's on the screen shows the timeline of simple active seizure to 5 minutes, then status epilepticus from 5 to 10 minutes, followed by refractory status epilepticus. To summarize the text on the left, it discusses that supportive care is all that is required during a simple seizure, that ventilating patient with a BVM may not be effective, and importantly that anticonvulsive medication should not be administered until status epilepticus is established. Airway interventions may be difficult in a tonic-clonic seizure due to trismus, but ensuring suctioning of secretions to prevent aspiration and consider a nasopharyngeal airway is fundamental care. These fundamentals are paramount prior to and after administering benzodiazepines. The benzodiazepines will need to be administered once the patient has reached status epilepticus, and aggressive management should commence to ensure termination of seizure activity. The Ambulance Victoria guideline for managing the seizing adult follows those general guidelines seen before. It reminds paramedics to ensure the patient has reached status epilepticus to consider the cause of the seizure and if any part of the management plan has commenced. If the patient is in status epilepticus, 10 milligrams of intramuscular midazolam is to be administered, or if microqualified, 5 milligrams of IV midazolam. Post-administration of midazolam, the seizure will either stop and paramedics are reminded to conduct basic life support interventions, or if the seizure continues and further midazolam is required, ALS can provide another 10 milligrams intramuscular midazolam after 10 minutes, making it a simple 10-10-10 rule. Micro can provide up to 5 milligrams IV after 5 minutes. Microparamedics can provide up to a total of 30 milligrams of midazolam, that is intramuscular and intravenous combined total. And micro are reminded to consult for further medication and to consider the need for intubation. The pediatric guideline mirrors the adult one, with simplified dosages for midazolam administration to reduce calculation errors in a stressful situation. These values closely follow the Royal Children's Hospital recommendation of 0.15 milligram per kilo of midazolam, and again reminding paramedics prior to and after midazolam administration to focus on fundamentals by watching airway and ventilations. One of the first lines within the status epilepticus section of the guideline is to provide oxygen therapy. A patient experiencing generalized convulsive status epilepticus has an increase on energy demands from cells, including neurons. Ensuring there is adequate oxygen to meet these demands is vital at preventing secondary injury to the brain. Providing high flow oxygen increases the fraction of oxygen at the alveolar level, leading to an increased exchange of oxygen at the cellular level thanks to partial pressure laws and Henry's law. It is important to note during COVID times that high flow oxygen is potentially an aerosol generating procedure. When we discuss status epilepticus in more detail shortly, we will look at intubation and when it may be necessary. The next few slides are some special circumstances that paramedics may encounter. Febrile seizures are seizures in children between the ages of 6 months and 6 years. The growing brain is more sensitive to suddenly raised internal temperatures and causes neuronal abnormalities leading to seizures. Overwhelmingly, these seizures are benign and don't lead to epilepsy. Most paramedics will not have to provide any interventions, but should not assume all pediatric seizures are febrile seizures. Follow the same guideline you would for pediatric seizures, and I would recommend having a read of febrile seizures from the Royal Children's Hospital website. Subtle seizures can occur in adults and pediatric patients and are extremely difficult for clinicians to diagnose. Patients with prolonged convulsive status epilepticus will have tiring muscles but still have seizure activity happening within their brain. So small muscular twitches or eye deviation may be present and should be considered in patients altered conscious and witnessed to have had a tonic-clonic seizure. For management of these, ALS will need to consult with the clinician for midazolam. If paramedics have a female patient presenting with seizures, however rare it may be, eclampsia should be considered as a diagnosis. The definitive management of an eclamptic pregnant patient is delivering the baby. If delivery is not imminent, magnesium sulfate infusion has been shown to be the best management for the eclamptic patient. Seeing as paramedics do not carry magnesium, the standard seizure management guideline applies due to the life-threatening nature of seizures. Paramedics are reminded to provide oxygen and left lateral tilt to reduce risk of aspiration while reducing venous compression. In the rare case of status epilepticus refractory to management, paramedics need to remember to follow the fundamentals of care. That while a patient is seizing, there is an increased risk of airway compromise and insufficient breathing. If patients are still in status epilepticus despite midazolam administration, different anti-seizure medications such as phenytoin, is needed as soon as possible. But we as pre-hospital emergency clinicians need to deliver a patient to hospital in the best possible condition. In some circumstances, loading code 1 to hospital and alerting the receiving hospital will be best for the patient, but overwhelmingly that is not providing best patient care. As we've seen, patients in status epilepticus are having increased metabolic demands by their body and decreasing oxygen input, resulting in anaerobic metabolism being utilized. Anaerobic metabolism results in lactic acid buildup, thereby resulting in metabolic acidosis for the patient. On the slide, we are looking at the indication for rapid sequence induction by mycoparamedics. I've highlighted the targeted treatment section stating status epilepticus is an indication for rapid sequence induction. These patients are high risk for airway compromise requiring regular suctioning, and as mentioned in Tintinelli, bag valve mask ventilation will likely be ineffective with a tonic-clonic seizing patient. What RSI also aids in is decreasing the metabolic acidosis that can build with continuing muscular contractions with inadequate aerobic metabolism. For clarity, muscle paralysis does not stop the seizure activity, but stops the muscular contractions evident during seizure activity. This means midazolam may still be required to stop the electrical storm going on within the brain. Careful monitoring of their vital signs survey post-intubation will be required, but an intubated and ventilated patient arriving to hospital with control of their airway and ventilation will be better than arriving with an actively seizing patient with no airway control and inadequate ventilation resulting in further hypoxia. The primary medication provided to actively seizing patients is midazolam, which is a benzodiazepine. As we discussed earlier, the reason for seizure activity is an imbalance between excitatory and inhibitory neurotransmitters. During a seizure, emergency providers are trying to hyperpolarize neurons to make it harder to reach action potential threshold. Benzodiazepines achieve this by binding to GABA receptors to enhance GABA's affinity for the receptor. This increased affinity increases the time the ligand-gated ion channel remains open, thereby increasing negatively charged chloride ions moving into the neuron, making it more negative, which means the neuron will be less responsive to stimuli. Unfortunately, benzodiazepines are non-selective, and all neurons are hyperpolarized. This also includes parts of the brain responsible for maintaining airway control and respiratory drive, which is why emergency providers are reminded to remember the fundamentals when utilizing this class of medication. Research by Mayer et al. In 2021 showed the use of benzodiazepines in the pre-hospital setting significantly reduced status epilepticus arrival at hospital. Why midazolam was the chosen benzodiazepine for pre-hospital providers was based upon research looking into varying benzodiazepines' effectiveness at terminating seizures and their ease of use for pre-hospital providers. In research conducted into the ease of use, midazolam was seen as a viable option for pre-hospital providers because it had a relatively short duration of action, being around 30 minutes when given intramuscularly, and midazolam can be given intranasally, intramuscularly, and intravenously. Midazolam was also part of a trial known as the Rampart trial, which was able to prove that intramuscular midazolam was as effective as IV lorazepam for the status epilepticus patient. The dosages of midazolam were chosen based upon the critical nature of status epilepticus and difficulty in recognizing subtle seizure activity. By utilizing arguably larger dosages, paramedics can completely terminate the seizure activity quickly, meaning they are less likely to miss subtle seizure activity. Giving advice to colleagues about scene leadership is difficult, and it will be contextual of if you are ALS or MICA, and it depends on if you're metro or rural. All I can say to all pre-hospital providers is to be suspicious of the seizing patient and to recognize it early. If you do recognize the status epilepticus patient, let the clinician know early This will allow things to happen behind the scenes, regardless of where you are. Being presented with a status epilepticus patient, regardless of cause, is a time-critical patient, and trying to do it all on your own will result in cognitive overload. As mentioned earlier, if you're a metro paramedic, you may be able to get the status epilepticus patient to hospital faster than waiting for higher level support, and this will need to be carefully weighed up. But rural paramedics may be the highest level of care in some circumstances. Early notification and early organisation for higher level of care will be needed for best patient outcome. Not all postictal patients present acutely unwell and don't necessarily require transport to hospital. Ambulance Victoria wrote a treat and refer guideline if paramedics are presented with a known epileptic patient who has had a single seizure. Transport is not necessary if the patient has made a full recovery, even if the patient has had their own medication administered by following their own management plan. But if paramedics are presented with anything atypical from a seizing patient, transport must be made for further investigation and management. To sum up, seizures are usually self-limiting, and for the first 5 minutes of seizure activity, emergency providers should rely on basic life support while preparing for deterioration. When paramedics are presented with status epilepticus, they should treat aggressively to terminate seizure activity. Post terminating the seizure, paramedics must remember the ABC. Thank you for watching. I'm just going to slowly go through my slides to show you my references here. Please feel free to reach out if you have any questions or any feedback. Thank you very much for watching.